Dr. Paull, welcome to the show.
Hey, Kevin. Thanks for having me.
Dr. Paull, this is a very special episode of Device Nation we're running. We're doing a BOGO promotion this episode. You buy one interviewer at full price, you get the second one free. Sitting beside me in the studio is LinkedIn luminary, Dr. Matt Barber. Thank you for joining us, sir.
Thanks for having me, Kevin. I'm just along for the ride here.
Dr. Paull, I think that what you're doing is significant enough to warrant an extra set of eyes and ears, so to speak, and give it the attention it deserves. So before we get there, our primary reason for getting together today, I'd love to hear about your journey. And let's go back. What put you on the path to a career in medicine?
Gotcha. Well, thanks for asking me that. So I never really, when I was a kid, it's not like I planned on going into medicine. No one in my family was in medicine. I come from a long line of engineers. You know, my dad was an engineer, his dad was an engineer, and so on and so on. And it was a fateful day, which was for me, it's December 28th, 1999. I was 14 years old, and I was skiing. And it was my first run that year, and I unfortunately had a pretty bad skiing accident where I skied into a tree. And I suffered a bilateral femur fractures, a left hip fib fracture, and a right radius ulnar fracture, you know, all at the same time. And I kind of went from being half dead to getting all fixed up, and
wow.
you know, got rods in my femurs and plates and screws, all the good stuff. And I went back to kind of a normal life not too long after. I mean, it was a recovery process, but in the scheme of things, it wasn't long. And I said, this is kind of amazing, and that kind of turned me on to really the world of orthopedics. I said, this is pretty cool. This is what I want to do. And since then, I just kind of put my head down and just kind of ran forward with it until that's kind of what I ended up doing. But yeah, that's kind of the short of the origin story. I mean, it's, no one in my family was a doctor. If this skiing accident never happened, I would probably be an engineer.
Oh, wow. So you went on to medical school in my old stomping ground, Miami, Florida, the University of Miami Miller School of Medicine. What was your experience like there?
Oh, I had an excellent experience there. So when I went to medical school there, they had something called the regional campus that was actually up in kind of in the Boca area, right. And I thought it was great. It is, I could walk to the beach. The education was excellent. It was, after spending all the time in the Northeast where I grew up in the cold weather, it was a pretty nice place, to spend 4 years kind of in your mid-late 20s, as you could imagine. So I had a good time down there, and I got a good education, and really I only have good things to say about it. I really enjoyed my time there. I mean, obviously, it's medical school, so I mean, you're working pretty hard, but like anything in life, it goes in cycles. So you'll have periods where you're studying really hard, and then all of a sudden you got some sort of quasi break, and you really could enjoy yourself during that time period. But yeah, that was an excellent experience for me.
Well, talking about opposites, you went from Miami, Florida to Toledo, Ohio. I always feel like I need to say Holy Toledo for some reason. It's just stuck in my head. You did your orthopedic residency there. I know you did some work, God's work, at Shriners Hospital. That had to be quite an experience. Tell us about your time there.
Yeah, sure. Well, when I was in Miami, I matched to Toledo. And so telling someone in Miami that you're going to Toledo, Ohio, it doesn't quite register.
Right.
So they go, "Oh, where are you going?" I'm going to Toledo, Ohio. And it would just be this blank stare for like 5 seconds. And they say, do you have family there? I go, no. And then that was the end of the conversation. Because for someone in Miami, Toledo, Ohio might as well be, the Arctic tundra of like somewhere up in Alaska. They don't really know.
Sure.
But I really liked it there. It was a great place to do residency, and Ohio is a really great state, and it's there's a mentality kind of in that area of the Midwest where it's like we know we've got some issues, but we're going to make it better. They're very committed to a lot of pride in the state of Ohio and really making it better, and that was nice. Also, for residency, you're working so much, it doesn't really matter where you are too much. You could be in the middle of New York City or San Francisco, and doesn't really matter. You're going to be in that hospital all the time. So in that regard, it's fine. The cost of living was low. The only thing I didn't like was the road construction, which is, out of all the places I've lived, that's the absolute worst. I mean, man, all you see is orange cones as far as the eye can see. And that's how it is over there. Yeah, to go back to what you mentioned, the Shriners Hospital, I was lucky enough to do a pediatric rotation down in Lexington, and that was phenomenal. I mean, that was a phenomenal place to learn and work for a little bit. I mean, that was all about education. The cases were great. The people were great, and it was really a benefit to be able to spend some time down there.
You went on to SUNY for a hand fellowship, and I believe that may be where Easy Orthopedics was born. Tell us about that whole experience and about that fellowship.
Sure. So the first thing to know is I did not complete the fellowship. So I only went halfway through. And it's not, look, when I interviewed for fellowships, I interviewed at a lot of places, and that was not my intention. I had I never thought I'd be doing this sort of business. I mean, I'm happy that I am. Life is weird like that. But yeah, so let me tell you the story of that without getting into too much detail. So part, of the pipeline, like I said, I decided at 14 years old I'm going to do orthopedics. And at that point, you kind of put your head down and just hammer away. You realize okay, I got to get good grades. I got to get into college. I got to get to, I got to get into medical school. You get into medical school. Well, now I got to get into residency. Well, I get into residency. And now I got to get into fellowship. And you never really have time to pick your head up and look around at what the ecosystem looks like. You're just so concentrated on getting through and moving to the next step. So, and I like hand surgery. And when I got there, after a little while, I'm like, okay, well, now the next step is for me to find a job. So let me look for a job. Now, my wife is from Colorado Springs, Colorado. And at this point, I've been dragging her all over the country. To Florida, to Ohio, to New York. And, I always said, we're going to go back to Colorado. We've got family here. And as far as I see, you got to live close to family one way or another, especially if you have kids. And we've got a young one. So that was what we wanted to do. And it's I can't find a job out here. Or the ones I find, it's a competitive market. It's, they want you taking their entire general call, every single day, or you're talking 4-month guarantee. And, it's not just me. I've talked to other docs who've tried to come out to Colorado, and it can be very tough. So it was just so that was part one. Part two is I interviewed out for a job in Connecticut, and all I could see was the senior partner being really bitter about how he used to make so much money in the late 80s, early 90s, and how bitter he is today. And I talked to a junior partner out there, and I'm like, hey, are you happy there? I just asked him that, And he's like, well, it's getting better. And I'm like, you're miserable. You know what I mean? And it's the senior, he's in sports, and senior partners have full case schedules, and God forbid they throw one his way. You know what I mean? And those things are going on. And then I kind of had a family crisis of sorts. So it was just existential and personal crisis all at the same time. And I probably for the first time, I picked my head up, and I'm like, what am I doing? There's, you always think of light at the end of the tunnel, light at the end of the tunnel. And I think it was just this realization that it's a series of tunnels, I'm just in this loop of tunnels with this kind of the, light between the tunnels. And, so I kind of went rogue, I quit my fellowship. I broke my lease. And I just moved out to Colorado. And I'm like, well, what am I going to do? And, looking around, I had one friend from medical school, and he does primary care. And he's down in South Beach. And he started this house call practice. And not only was he happier than anybody I knew, he was also doing better financially than anybody else I knew. So it was kind of this, I don't really know if this is going to work, but I'm just going to go for it. So that was kind of how everything started. And it was I know I'm an orthopedic doc, I'm not a primary care doc, and I don't know what this looks like for orthopedics, but let's see if I can't figure it out. And that was kind of the start of the journey. And I mean, I had to figure a lot of things out. What does this look like? How does this work? And at the time, I was living with my in-laws, living in the basement of my in-laws, my wife and my kid. I'm trying to figure this thing out. Meanwhile, friends coming out of fellowship, their colleagues, making hundreds of thousands, and I'm here rubbing 2 sticks together in the basement. But that was the start of the journey.
Daniel, this is Matt. In hearing about your practice, I mean, that is exactly what comes to mind is this model of direct primary care, which I don't know if the audience is entirely familiar with that, but is sort of an offshoot, if you will, of that concierge type care, particularly in primary care where somebody pays basically a retainer amount to a physician and they take care of them for the year on a cash basis. And obviously an internist armed with a lot of knowledge and a few good lab studies can take care of a ton of stuff for a patient on a pretty low cost basis. I've always been intrigued with this idea of how this translates to really not just orthopedics, but anything surgical, where you've got hospitals and ambulatory surgery centers and things involved and sometimes implants. And was there anybody else doing anything similar or any kind of model you went from, or did you just jump in this thing?
No, yes and no. The only models I had were based on primary care, so there wasn't any orthopedic model. I had to figure out everything from scratch. Like, what does this look like for the specialty? And just to kind of, I think something that I find confusing that's good to clear up is the difference between, so you're right, direct primary care doctors, the basic idea is a patient says, hey, let me pay you $100 a month or whatever it is. And the direct primary care doctor says, that's great. I don't take any insurance. You can come see me as much as you want. You can get labs at cost. You can get medications at cost. They have a lower patient panel. They can call and text their doctor. To me, I think it's better medical care. And usually the doctor is much happier, right? They're not dealing with insurance or hospitals or anything. And the patient is too. So that's kind of your direct primary care world. And that's been around since probably 2010, and that's been expanding. Concierge medicine, which kind of people conflate the two, is really when you have an insurance-based practice. And then you bill the patient on top of that, meaning that you bill them for insurance and you say, hey, if you want extra access to me, it's, $1,000 a year or $2,000. They tend to be more expensive. But it's a subtlety there. And, when you talk about concierge, you think of like high society type stuff. In direct primary care, there's a lot of, small business owners or people that don't have insurance, and it ends up being a really excellent option for them to get high quality medical care. So, but yeah, to go back to what you said, so figuring this out for orthopedics, there's a lot of things to figure out. The first and foremost is that I don't take any insurance, and I think that's super important. The model I'm doing is completely incompatible with that. If I were to take insurance, I would have to hire 5 people. And by the way, my office staff is me and my wife, and for a while it was just me. And that's all I need right now. But I would need to hire 5 billers and coders, and then all of a sudden, okay, well now I need to pay these 5 billers and coders. I need to hire, I need to see a lot of people, and all of a sudden you're running this volume-based game, volume-based practice. So it's high overhead, high volume practice in the insurance world. And, you end up spending less time with patients. And in my opinion, you do a worse job. It's like asking someone to paint the wall of a house. Here, you can spend as long as you think you need to paint this wall and do a good job. Or here's 10 minutes to paint this wall. You can do it. May not necessarily be a good job, but you can do it. And I think that's kind of the ecosystem now in orthopedics. If you're seeing 50 people a day, which, some of these guys who are really busy are, you don't have a lot of time with the patient. You can come up with or more. Yeah, I've seen it. You can come up with a diagnosis and treatment plan pretty quick, but that doesn't mean the patient understands, what the hell you're talking about. Oh, what did the doctor say? I don't know, something with my elbow, but I need surgery next week. It's not good care. Even if you meet the standards of care by definition. So it's a different model. It's low overhead, much lower volume, and I spend a long time with people. And I've taken this from the direct primary care doc. Instead of a transactional based appointment, it's relationship based, meaning that I just spend more time and you really develop more of a relationship. And I think that leads to higher quality of care, in my opinion. Same doctor, right? But just the business model of delivery is different. And I think it's superior. But yeah, if you're stuck in this insurance world, the problem is it's not static. So your overhead goes up as time goes on because insurance companies are not incentivized to pay you. And what that means is they make you jump through more hoops. Not only does that waste your time, you need to hire more staff, higher overhead, not to mention office space requirements that you need. How many of these offices have just a whole floor, a whole area just for billers? And then, overtime reimbursements go down. So you end up working harder making less. And in my opinion, delivering crappier care as you see more and more people. But that's kind of the core of the business model. So yeah, I don't take any insurance. I don't take Medicare. I don't take TRICARE. Don't take Medicaid. No, nothing. And because of that, I'm super lean. I don't, even my medical record system. I mean, what do you really need in a medical record system? You need something that keeps notes for you, and that's HIPAA compliant. I don't need an EMR that people buy. I mean, those are made for billing. That's why doctors don't like them. It turns doctors into billers. Docs don't like that. And they're clunky and they're expensive. I pay $12 a month per user for my HIPAA compliant Google Drive through G Suite, and it's just templated word notes and orders, and that works perfectly.
That's awesome. You
but,
jumped on a bunch of stuff
yeah.
there. And I think,
yeah.
it's relational, as you said, but it is transactional, but it's a transaction between you and the patient. We've cut a lot of processors out of there in terms of insurers that are making you jump through hoops, and then, as you said, all the hoop jumpers that you have to hire to make that process go. So that's an interesting way to look at it. What have there been any major roadblocks to it? What have been the hurdles for you?
Yeah, sure. So, like I said, so I didn't start with an office. I still don't have an office, and I don't really need one. I do, house calls, or I'll see someone in an office, which is at an imaging center, which they just let me use. We don't have a financial relationship. And I found that with me traveling, other docs say, "Hey, can you come into my office and see A, B, or C, and cast them or something?" And I'm, sure, and I'm added value. But to get to answer your question, what roadblocks? So the roadblocks can be kind of significant. So there's not too many roadblocks to actually starting your practice. Buying supplies and everything is not too bad. Getting the surgery part set up was very difficult, and I'll tell you why. So I need, you need to find. So I'll just give you this story. So there's a surgery center in town, a local surgery center, not owned by the hospital. Perfect, right? I go talk with the CEO. He says literally these words: "I'd love to have you here. Love to have your practice here. Great, right? Place to operate. Just go get admitting rights at this gigantic hospital down the street." Now that poses two problems. One for me is that I don't want to. And the reason why I don't want to is because I don't really support these hospital systems in a lot of ways. I don't think they're the hospital systems of old that really provided community and charity care. They'll bankrupt, they'll see somebody, a patient, essentially bankrupt them and send them to collections, and then they're nonprofit. So not only are they bankrupting people in the community, they're not paying taxes to the community either. And as a doctor, you have all these MBAs and these other non-practicing positions and management, and it creates all these issues. So I fundamentally and philosophically don't agree with what they're doing. I mean, you need hospitals. I'm not saying that. It's just the way they've taken over care I don't agree with. But that's one point. The second point is, they would force me into the call pool. I opted out of Medicare. Probably I don't have an office. Well, I guess I kind of do now. At the time I didn't. So that's not a great fit. But the real stumbling block is that somewhere on that credentialing board is another orthopedic surgeon. And as you know, we don't always get along that well with each other. And this is a chairman orthopedic surgeon, which is kind of a special type of breed. And as a solo practitioner trying to go in a competitive market and get admitting rights, they're just going to say no. They'll just deny you. So I had to find a way to work around that. And that was a tough one, because a lot of these surgery centers, they take Medicare and Medicaid, and an old requirement that was actually removed a year ago for Medicare, so that you have to have all your physicians have admitting rights. Now, in concept, that sounds good, right? Something happens to the patient, you can take them to the hospital. But if something happens with the patient, they go to the hospital anyways, and they'll get standard of care. It doesn't really matter who's sending them over there. When someone gets in a car accident, no one is, or anything happens to them, they go to the hospital. So what I had to do was I had to find a surgery center that didn't take Medicare or Medicaid and didn't have those requirements. And I was able to, but it took a lot of effort. And, this surgery center, it was built for an oral maxillofacial surgery. So I've essentially been slowly putting surgical equipment in there. and it's a process. You know, I don't have everything I need right now. There's certain things I can't do because I don't have the tools that I need. You know, I'm just gradually, you know, like I just bought a full size C-arm, you know, a month back, refurbished, of course. But that's a process, and that's been difficult.
So does that, by definition, limit you to essentially all outpatient surgery?
Yeah. So yeah, the way the model is, it's essentially all outpatient surgery. I don't really have a strong desire to do inpatient surgery. I'm not really set up for that. You know, also if you're working in the world of cash to keep costs low, you really can't be doing things inside a hospital system where you have no control over the billing or the cost.
Agreed. In Colorado, are you able to do a 23-hour observation or keep folks overnight in a surgery center? I know that varies state by state.
Yeah. Yeah, you can do that, and this place is capable of that. But yeah, it was a hard problem to solve. Not as easy as I thought, and that's part of the thing about creating a new model or new way of doing things. You come into these roadblocks you didn't think they were there. That were there. Sometimes they're easy to get over. Sometimes they seem impossible. But I found with enough time and effort, you usually can figure these things out. But yeah, so that's kind of the situation with that.
The hospital credentialing admitting part definitely seems like, you know, it would be one of the stickiest things in terms of, you know, as you say, if there was an issue, which admittedly is a very, very rare fraction of the time. Has there been any pushback in your community from orthopods or hospitals or anybody about what you're doing?
No, I don't think. No, not yet. I don't think they're really aware of what I'm doing. So, I mean, I kind of stay off
Still
radar.
under the radar.
You know?
Yeah, that's awesome.
At least right now. I mean, look, I don't affiliate with any insurance companies or hospital systems. I mean, for all intents and purposes, I opt out of Medicare. I'm off grid, which is where I like to be. So they don't really, right now, they're not really paying too much attention to me. When I start disrupting them eventually, then maybe they will. But by then it'll be too late for them.
So for physicians or surgeons listening to this, talk to me a little bit about logistics. With your EMR, are you giving people CPT and ICD-10 codes that they're then taking back and getting reimbursement from insurance companies sometimes for populations that you take care of that may be insured? How do you get labs, imaging, DME, all those sorts of things? Sure.
So generally, I'm not generating those ICD and CPT codes. I mean, if you're seeing someone for cash, there's no need to. Those CPT codes are owned by the AMA, and that's the insurance world. I mean, I'm not in that world, so I don't need to do any of that. And sometimes it's as simple as me seeing them. At the end of the visit, they give me, they pay for the visit either by credit card or by cash, and that's the end of the financial transaction. That being said, when I say cash, I just mean really not insurance. So there's such an apparatus of billing for insurance. Cash can be anything that's not insurance. So that does mean cash, but I also take medical liens as well. What that means is that if someone's, let's say, in an accident or a car accident, they've got a case going on, I can essentially put my payment, a lien on that medical case, meaning that when it settles, I'll get paid, which could be a year, 2 years, something like that. But I don't need the overhead to collect, and for me, that works fine. So then I'll generate some CPT or codes, but nobody's auditing the chart. I just say this is what my fee is, and this is the time I spend, and I think that's fair. And
sure. And your patients
nobody.
agree
It's not
to
like
that,
the
and y'all
insurance
have had a
world. Say you didn't do right. It's not like just saying, hey, you didn't fill out the review of systems or whatnot. So I don't need to generate that. As far as figuring out imaging, I'll see patients at an imaging center, and they have some offices that aren't really used, and it's all cash prices. So the beauty about that is if I say someone needs an MRI, I can get an MRI the same day, and it's much less than it would be through insurance, especially if they have a high deductible. So someone's paying $350 for an MRI. If you have insurance, you have a high deductible, you could pay $1,000, same MRI, and I don't have to spend an hour on the phone. Talking to one of the big insurance plans, trying to convince, a nurse who's 5 states away that somebody needs an MRI based on the exam I did. So that's certainly a benefit. As far as labs, there's a local primary care doctor who, if someone needs labs, they'll send them over there, and that usually takes care of that. And you can get pretty low negotiated lab costs. And DME, I basically just bought some DME and I carry it around with me. And if I think I need to use it, then, it's not super expensive. I can, give out a wrist brace or a splinter or something like that. So those problems weren't super difficult to solve. And I think at least in the world of, direct payments or cash, the imaging thing is a lot easier. But yeah, certainly if someone says I had a fall and I hurt my elbow, I'm going to say, well, you need x-rays before I can see you, and I'll send them to imaging before I see him, or I'll see him at the imaging center.
At least on my radar, it seems like, too, a lot of these imaging centers have definitely made a push toward having cash pricing available for folks that are uninsured, or exactly what you described, a situation where they're insured and have a super high deductible, and it's actually cheaper to pay for the study outright than to pay their copay or deductible on an insurance-priced exam.
Yeah. I mean, that's the insanity of it, right? I mean, it's not like it was 20 years ago where, you had a good insurance plan, wide network, low deductible, and kind of just paid for stuff. You don't have that. I mean, now you have high deductibles, networks are razor thin. You have no idea what you're going to be paying. So even if you do have a good insurance plan, it may not cover anything. When you get in the world of, cash, it may actually be less if you just pay out of pocket, and it's easier for you. You'll get it faster, and it's easier for the doctor too. It's just you just cut out the middleman. That's really not adding any value. I think that kind of comes back to the core of what I'm trying to do is cut out all these middlemen in the healthcare system that aren't adding any value. They're not adding anything to patient care. I mean, you look at some offices and they take a picture of their office staff and it looks like a football team. They've got so many people. And if your office picture looks like a football team, then you're going to have issues. And most of those people are non-clinical. And you got to ask yourself, what are they really adding? What is all this really adding to the doctor-patient relationship? What do you really need? Well, you need a doctor or provider. You need a patient. And it turns out you really don't need much else. And that's kind of what I've been doing. I mean, obviously for surgery, you need a lot more staff. That's a different animal. But for most interactions, you really don't need all that stuff.
In a very broad sense, and if you try to run them down a little bit by category in terms of demographics and what they're after and what these relationships are like, who are your patients in this model?
Gotcha. So, right. And that's a great question, what my patient population is. So, I don't take Medicare. So right away that cuts out mostly everybody over 65, right? Which cuts out a whole subsection of orthopedics. I do see them sometimes, people, over that age, but, it's because they're mobile, they can't leave the house, they really need someone to come see them. So most of the people I'm seeing are uninsured, or they have insurance with a very high deductible, or they're sometimes involved in some sort of like auto accident. So the population tends to be healthier and younger. Most people are probably around middle income. I do see people on Medicaid. I don't take Medicaid, but I'll see them through one mechanism or another. As far as wealth, sometimes I'll see very wealthy people. It's definitely not the norm. I know when I tell people what I do, they think I'm just seeing, super rich, fancy people all the time, and it happens. But that's not that's not what I normally do. That's not most of my patients. I have been in someone's house. I get in their house, we go in their elevator inside their house, and the elevator's squeaking, and she's like, "Oh, I got to call the elevator guy." That's just not a problem I've ever had that most people have. But you do see that, or all walks of life, especially doing house calls. I mean,
sure,
you see all sorts of things.
Well, and that's, if I'm looking at this from the sidelines, of that would be my gut reaction, or my feel of this, is that you would have certain maybe high net worth individuals that, for lack of a better term, this becomes DoorDash for orthopedics, and they can pay for a very high level of service that saves them a lot of time, but then that there's probably a middle ground of uninsured or underinsured, or folks sort of locked into these, painted into these high deductible corners, if you will, that just need, humanely priced care and need good service with it. And maybe that reaches into my next question about who are your strategic partners. Do you have a lot of Medi-Share type groups that want to contract with you, or where you're identified by them or by some of these direct primary care providers as being a resource for orthopedics?
Yeah, so I definitely do go to direct primary care doctors, and they are a referral source for me. With the Medi-Shares, that's been more of a work in progress. I've certainly tried to do that, but sometimes these relationships take time to get that going. My next real target is employers. Really, direct primary care doctors are doing this, and I think they're really far ahead of us because they've had to be. So they've hit this kind of pain point squeeze, in this volume insurance billing game, where they're so unhappy that they've kind of had to find another way of doing it. Happy, and also it doesn't financially work that well. So they've kind of created their trailblaze the path in direct primary care. I think orthopedics maybe eventually will get there. We just haven't hit that same pain point yet. We will, trust me, but we're not there yet. So that's kind of where I got the idea for that.
I think it's who your
right,
strategic partners are, and you spoke to that, I think, in terms of some of those direct primary care doctors, and where a lot of us, I think, are getting to with some of these direct to employer contracts, where we can contract for particular things and particular services. And even these companies that provide insurance to employers, they realize that by pursuing these relationships directly, they can essentially cut their cost by, again, as you've talked about, cutting out the middleman and going directly to somebody that provides the service, and then contracting for it.
Right. Yeah, that's such a great point. So, employers, health insurance is getting so expensive. You think of it on the individual level, but you got to remember, employers are paying the brunt of it. So if you're working somewhere and you're not getting a raise, it may not be because it may be, one of the reasons could be because the premiums go up every 20% every year. So instead of you getting a raise, that 20% goes to the healthcare companies, to the insurance companies, and the broker who sets this all up, they get paid a percentage of, the premiums. So they're not trying to stop this. So a lot of employers are really getting squeezed. They're going, how can I contain these costs? And what some of them are starting to do is they go, you know what? I'm just going to pay for everything out of pocket cash. I'll get a stop loss insurance policy if things get too far out of hand. And they look for cash-based, solutions that provide exactly what you said, direct contracting. And I think in the world of orthopedics, essentially, as musculoskeletal cost containment, that area hasn't really been tapped. So that's something that I'm working on. But negotiating with employer groups is not something you kind of do overnight. It's something that takes time. But I really think that that's an area that needs to be explored, definitely. And, things are so crazy right now that what some employers will do is they'll pay for someone to get surgery, down in Mexico or Costa Rica, and they'll pay to fly their employee out and their employee's entire family out. And in some cases, they'll even fly the surgeon out from the United States. And that ends up being less expensive than doing it down the road at your local hospital. So, things are kind of insane. And they're just trying to make some sense of the insanity and find some way to just prevent these costs from going off the rails. And, my goal is to do that and to have these companies drop their insurance plans once they realize that they're not actually providing any value and that they're incredibly expensive. I think that would be a real win, because these things aren't going to change unless something makes them change. And I don't think you can really do it from a legislation standpoint. I think it's got to be done from an economic standpoint.
I think you're exactly right, and it's curious that insurance or commercial insurance for healthcare, really at its heart, I think, started as the, quote, major medical, if you will, which was that, most of my care I could handle. I needed to be able to budget for this and plan for this in my life, and it was affordable to some degree and humanely priced, and I just needed insurance there for risk mitigation, car wrecks, cancer, things that were just beyond what normal people could cover or afford if it happened to them. And then it evolved into something entirely perverse and different, as you've described. So I think you're exactly right. And then I think the flip side of that is employers that are, like you said, get a stop loss policy. They can buy all these services a lot cheaper and then just have an additional reinsurance policy, if you will, for risk mitigation of really catastrophic events that are exceedingly rare.
Right, and I think that way kind of made more sense, and we certainly moved away from that. I think when Medicare came out in, I think, 65, it kind of blew the doors open on all that, and that's when you saw prices rise a lot, and a lot was from physicians, because at that time Medicare would just pay reasonable and customary. Well, if you and the four other surgeons in town, start charging more, well, then that's customary in that area. And then I think that all changed in the early 90s when they introduced the RVU system, and then it's kind of been clamping down since then. And it makes it tough because, if you end up working harder and over time, reimbursements only go down. So if you look at joints, right, and I don't do any joints, but the reimbursement for joints, at least out here in Colorado, you get paid less dollar for dollar for doing a joint now than you did 20 years ago in the year 2000. And that just keeps trending down. And, if you're a doctor and you're reliant on all these insurance payments, right? Because if Medicare makes that decision, a lot of insurance companies will say, we pay 120% of Medicare. You really don't have much. You're kind of forced to take it. And, like I said, as the overhead requirements go up, I think it's just a losing game in the long run, not only financially, but just also frustrating. It's very frustrating, and, all the mental strife that it causes. For you to know that you're working harder now and you're not doing as well, and you don't get to spend as much time as you did maybe before. So that's kind of where I see that going, and not just for joints, but really for all orthopedic procedures. I think ophthalmologists, now maybe one of you guys will know more than me, I think ophthalmologists used to get paid a real lot for doing cataracts in like the late 80s, early 90s. And at some point, Medicare clamped down on it, and I think they get a fraction of what they did then. And so they moved it from hospitals to ambulatory surgery centers. Now then they start moving it into their offices. But where are they going to go next? Their car? It's a losing battle.
Dr. Paull, when I lived in Miami, I saw many a doctor's office with a sign on it that said, we do not carry malpractice insurance. And I was just curious, what does that landscape look like in the concierge world?
Gotcha. So, yeah, malpractice can get so expensive in Florida, like I say, especially for OB-GYN. It's so obscenely expensive that the doctor will say, you know what, I'm putting all my assets in my wife or my husband's name, and I'm not carrying malpractice, and they end up not having any assets. So that's the strategy down there.
Right.
So, yeah, for me, it took a fair amount of work to convince, find the appropriate broker who could find the appropriate underwriter that this actually isn't very high risk. I don't see that many people. I spend a long time with them. Communication is good. When communication is good, you usually go get to. But yeah, certainly starting off, purchasing a full-time orthopedic surgeon malpractice is super expensive. So that's not really what I did, in the sense that I purchased a part-time policy, and that ends up being pretty affordable. And if you look at the amount of hours I work, it is part-time. I spend time working on the business, but as far as patient care, it is part-time. So that was actually pretty affordable. But it took some effort to find and to get. But yeah, if you're not working a full time by their standards, you can certainly get partial policy. Some states don't require you to have it. Colorado is a state that does. And I'm obviously happy to have it. But that was a problem that was it wasn't super difficult to solve. It just took some time and effort.
Two strategic questions for you. The Surgery Center of Oklahoma has really tapped into this growing market for price transparency, cash pay surgeries, given the high deductibles. Do you see a possible strategic confluence between what you're doing and these all-cash ASC models?
I think the Surgery Center of Oklahoma is like the model to kind of follow right now. And you got to remember, for cash-based surgery, there's not that many places, so your catchment area is very large. And I think that's something that I would like to build out here. Obviously, I'm working on that, and that just takes time. And, that's the eventual end goal, and if you do it right, you'll get people from all over the place. But I think there's that's the business model of cash pay. And if you start combining it with insurance pay models, it's hard in any business to get two business models working at the same time that are different fundamentally. So the benefit of cash pay is you don't need all this overhead, and of all these coders and billers. So it's sometimes difficult to do both at the same time. And it's kind of sad in a certain sense that if someone says, "Hey, I do want to pay cash for this carpal tunnel, how much is it going to cost?" And those surgery centers say, "I don't know. Nobody knows." Like, how do you not know? Well, anesthesia costs this, facilities this. Why can't you bundle it all together and give somebody a reasonable price? But they can't do it. It's not built for that. It's this opaque pricing, where they keep everybody in the dark on purpose. And if you're in the world of insurance, things are covered, they're not covered. But if you're in the world of cash, you can really get creamed by these billing practices because you just don't know what you're paying. And I mean, what else do you buy where you don't know what you're paying? If you're buying a car, a house, or anything, you're buying, some apples at the supermarket. I mean, you know what it costs. Why is it that for, surgical things or in the healthcare world, you just, nobody can tell you, or if they give you a quote, it's not binding. I mean, what's that worth then? But yeah, Surgery Center of Oklahoma, as far as I'm aware, just does cash. And that's all they do. If you start doing both, I think it's hard to do both at the same time. I think one of them will ultimately win out, and it will likely be the insurance model because that's where all your resources will go.
Yeah, I was thinking possibly kind of a joining of these two mindsets of having a cash pay concierge model feeding the all cash ASC and kind of joining forces to do it all under one roof. So,
yeah, I think that ultimately I may end up going into that sort of model. But when figuring all this stuff out, it's piecemeal. Solutions that come up aren't perfect solutions all the time.
Right.
And I kind of just have to build as I go. I mean, when I first started, right, I had no idea how to get any patients or do anything. I said, "Oh yeah, hotels," right? Because at this point I'm just doing traveling, right? And I'm like, hotels would be a good thing. So I went to some nicer hotels and I'm like, "Hey, this is what I do if anyone, gets injured or sick or whatever." And they just wanted me to leave. They did not care what I was saying at all. I gave them business cards. They probably threw them in the garbage, It's like, okay, that doesn't work. Let me try this. I'm like, oh, CrossFit. Yeah, CrossFit people get hurt all the time. I'm like, this will be good. So I go to a few CrossFit gyms, and I talk to them, and they're very nice, and they're very, they listen to what I have to say, and then never get anything from them, And I'm like, I realized, CrossFit people hate going to the doctor. They won't go to the doctor unless their arm is falling off, and even then, they probably don't want to go. And it's just been kind of, walking, trying to feel your way around the dark to figure out what actually works here. So it's a lot of trial and error. And I think any venture like this is a lot of trial and error. But, you can have a lot of failures, but you only need a few successes to really do well. As long as you're smart about it. And be careful who you contract with.
I'm a bit older than you, and I remember a show called Trapper John, MD, and the doctor had an RV parked out in the parking lot at the hospital. And I'm just curious, is this on the radar of creating kind of a mobile office to have some of the imaging equipment and be able to bring an office to somebody's house?
Yes and no. I mean, so when I first started, I didn't have an office, so mobile had to be it. And there are certainly people that are like, "Oh, I'd love that you can come into my house." And it worked out really well. There's other people, and for me, the cost is the same. Whether I go to your house or you come in the office, it's the same cost. I built it that way. They would rather see you in an office, so I don't really. Okay. It's hard to say, but I will say that I do carry around a lot of things. Steroid injections, casting, splinting. I can do mostly anything you do in an office. And recently, I got an ultrasound, a point-of-care ultrasound, and that's been phenomenal. Because, now I can look at someone's rotator cuff while I'm at their house. Or, if they think they injured their SL ligament in their wrist, I can have them clench their fist and I can look at it right there. And I'm still learning it. And it's, I didn't graduate too long ago, but ultrasound just wasn't part of the education. And I really think that it probably should be because there's so much value of just being able to image these things immediately. and increase the accuracy of your injections. So that's kind of where I'm at as far as like mobile care. At some point, will I add more to that? Possible. But right now, that's kind of where it's at.
What's been the response from patients just overall to this model, and what have been the wins?
Yeah, they love it. I mean, they love it because when I'm seeing them, this isn't a short visit. You're looking at 45 minutes plus or minus, depending on the person. They get to sit down and talk, and I think they really like just being able to spend time with, the doctor, with me, and being able to have all their questions answered. I mean, when I'm done, there's no questions. And if there are questions, I give them my cell phone number, and they can call or text, and I encourage them to do that. So some people may say, oh, I don't know if I would do that. But all right, let me ask you this. So if you see a patient and you're delivering care, and they go home, and they have a question, what's the process for them to get an answer? They call the office, the front desk can transfer them to the medical assistant, and the medical assistant has to find you and ask you the question. Then you got to tell the medical assistant the answer, and the medical assistant has to go and tell the patient. You're still answering the question. It's going through like multiple people, and half the time, if you look at Google reviews, of orthopedic practices, complaints are, it's communication. It's all communication. So why go through all that? I just have them call or text me, and you know what? I don't really get that many calls or texts because I spend a long time with them and they have their questions answered. So they really like that, even if it's just a text here or there, just being able to this goes back to the relationship-based model of care, which I just think is so much more powerful than your standard transactional appointment. If you're in that world and that's all you're like, well, what else would I do in that time? But, in the model as it exists, in that model, the transactional model, there's no time for patient education. Insurance isn't going to pay you for it, and it's not factored in. And I think that's super important part of the visit. What's the expectations? What do they need to know? Explaining things. And you can try and do that in a short visit, but it's tough. I mean, the system does not really allow you to do that, especially when your clinical manager books 2 people at 8, 2 people at 8:15. I mean, your PA seeing all the new patients. I mean, it's not the same as being able to just sit down and spend time. And I do think there is a difference with that.
I think you're right, and I think that physicians and surgeons are pushed towards more volume, and some of the educational parts either just go away, or at best they get delegated to a nurse, a case manager, someone else, and in a really well-designed system, they understand that practice and they know what's going on and can educate and can answer questions, but there's certainly the possibility of gaps, and it's certainly not going to be the same knowledge base. So I think patients do appreciate what you're talking about, and I think it is a different model. And when you've eliminated a lot of the overhead cost, then maybe it's effective to do that again.
Yeah, it's a different way of thinking about it. I think you'll find that if you kind of slow things down and spend more time, which is impossible in the insurance world, you'll go out of business. You can't do it. You'll find that these subtle differences actually really add up to make into something significant. But yeah, I think that's kind of an interesting point that you brought up with this volume, and you're expected to do this volume. So in the ecosystem that it is, I mean, surgeon is measured by basically the worth of how many surgeries they're doing and how fast they're doing it. So I think sometimes there's also a conflict of interest there, and not with everybody. But if a surgeon's whole practice is based on me doing surgeons doing a bunch of surgeries, that's when you start to find guys whose indications get a little bit loose. They start booking things a little bit more than they should have, and some people won't. And then the problem is that they're not doing that, they get pushed out by their partners or get pushed out by the hospital system. I heard a story one time of a prominent shoulder elbow surgeon, and he wasn't doing as much volume as the hospital administrators would have liked. And it's like, well, why didn't you operate on this guy? It's like, well, he didn't meet the indications for surgery. Well, you need to expand your indications, and that, whether it's explicit like that, it's either explicit or it's implicit, but that's happening. And I think patients are sometimes becoming privy to that as well. And I think that's a tough spot to put a surgeon in. And as a surgeon, that's a tough spot to be in. knowing that if I don't keep my blocks full, I'm going to have issues. And whether you admit it or not, I mean, that's a conflict of interest.
I think that's very definitely a concern, and I think that it's easy to envision that happening if you look at a lot of models of what's happened in other specialties where a lot of private equity money has come in terms of even dentistry and pain management now, and some in ophthalmology, dermatology, some of these type things, and it does encourage broader indications and more service to make more money. That can definitely happen. So very broad and very conceptually, to play the other side of this, I think there's historically been criticism of medicine as a cottage industry, where you had all of these doctors that were basically, doing, in some sense, whatever they wanted, and were not always, we as a profession were maybe not great at policing ourselves as far as what was going on and what was out there. And so some of this commoditization, this corporatization of medicine, maybe their argument is that we're making it more standardized, we're getting best practices in. One, is that real? Is that even a thing? And two, how do you account for this if you're sort of democratizing and decentralizing things the way you might in this direct care model?
Yeah, well, I'll say this. If you're, the doctor-patient relationship, I think, is a fundamental relationship, and I think really the doctor really wants to get the patient better. I think that's usually almost always the case, right? When you start bringing in all this private equity and people that are multiple levels removed from the patient care, they don't care about any of that. They may say they do, but they don't. They're just trying to make money. So they'll say whatever they need to or do whatever they need to make money. I'll give you another example. This is a particularly kind of mortifying one. So I know a family doctor out here, but she used to work out in Kansas, and somewhere in Kansas, I'm not sure where. And she used to do deliveries, as a family doctor would do in a rural area. And she had a CRNA that was supposed to help her, with she needed to do C-sections. And he was supposed to be on call all the time, but for whatever reason, he decided he wasn't going to be. I don't really know. But what ended up happening is she'd see somebody, and then if they needed a C-section and the nurse anesthetist wasn't available, she would send them down the road to the hospital system, right? Because what is she supposed to do, right? She doesn't have an anesthesiologist to do these C-sections. So she had a meeting with the CEO, and the CEO says, "Why?" She said, "We're not making enough money on the. We're not making any money with the delivery. We're losing it on all the the prenatal care. Why are you doing this?" And she says, "Well, I don't have this anesthesiologist, and I can't do the C-section, right? Like, you wouldn't do surgery. I wouldn't do surgery without an anesthesiologist. In most cases. I mean, if it's an invasive surgery like that." And what he told her is, he said, "Next time that happens, you inject lidocaine and you cut the baby out." So,
wow.
So I'll say it again. You inject lidocaine and you cut the baby out. So these are the types of, and that may be an extreme example, but, I just don't believe them. I just don't think they're interested in that. I think they're interested in making as much money as possible. They don't really care about much else. And, that's kind of,
I think
that's the way of doing things. And,
yeah, I think that's a concept that's pretty easy to believe. I don't think anybody's going to fight you a lot on that statement. So, from a consumer basis, do we then, with the internet now, do we have enough access to information that the patient / healthcare consumer is then able to regulate quality, and that as a market will regulate itself through reviews and through sort of digital word of mouth, if you will?
Yeah, I think that's part of it. And that's a very difficult question. A hard, thing to figure out is how do you regulate quality? Well, some go through medical school and they go through training and they pass their exam. But as the quality from one provider to the next isn't always equal. I like to think most of them are very competent, and, usually very good at what they do. But certainly if there is free market forces in play, if there's a doc who's not making very many patients happy, and you can interpret that how you will, then they will get less business. But I mean, you're talking about a pure free market, and that's just not what we have. And I don't think we'll have that anytime soon in medicine. This insurance model is not going anywhere for a very long time. I think you'll find small pockets of defectors like me and direct primary care docs and others who decide to leave that and have this kind of small free market bubble. But yeah, I mean, if you've got good insurance, like I said, I'm not usually, you can submit for out of network benefits, but a lot of people don't want to do that. They just want to go somewhere that takes their insurance, and then I encourage them to do that, and that's fine. But I do think that there does need to be some more little decentralization. You have either, if you're an ortho doc, you can either work for a gigantic hospital system who doesn't care about you, or you work for a giant private practice company, a private practice where it may be similar. And you're finding that these private practices, solo, I mean, that's not around anymore. Besides someone who's doing, went rogue like me, and you find these larger groups, and they're having a tougher time surviving. Competing with this volume and decreasing reimbursements, higher overhead costs, and they're getting swallowed up by these hospital systems, and it's just these massive conglomerates. And I don't think that's really good for specialty of orthopedics or probably any other specialty. I think that doctors need to be independent to a certain extent, and that allows them to just do what they do. And when you start constraining them in these ways, I think it does affect care. And then, look, docs aren't happy with this either. Most docs are, honest to God, pretty miserable. It's the highest suicide rate of any profession. I mean, there's a reason for that. And I think at its core, it's an awesome job, and I really like doing it. But I removed all the parasites, so I can practice how I see fit. And with all the parasites still present, you don't really have much of can't make too many decisions about how you want to practice. I mean, and the screwed up part is that they'll take away all your control of your practice. So they tell you how many people you're going to see and A, B, and C, and what you need to document, but nobody wants to touch the responsibility. No, doc, that's yours. We're not touching that. So you lose all the control of your practice, but yet you keep all of the responsibility. Nobody wants to touch that, right? And that makes a very difficult situation for a doctor. And that makes it hard. You go into this because you want to help people and make them better, and you have no time to spend with people. Even if you do a successful surgery, they come back and they say, "Hey, I feel so much better. Thank you." You're like, "Okay, great, bye." Or, you spend 2 minutes, or your PA sees them. So it takes, a lot of the fundamentals of, why this is a good job and why it's enjoyable, kind of have been shifted away.
Dr. Paull, just absolute respect. I think both of us know this took a lot of courage, and we can go Colorado here to paddle upstream on your mission to reinvigorate the whole doctor-patient relationship. How do people in our audience learn more about you and Easy Orthopedics?
Right. So I've got a pretty good website called easyorthopedics.com. You can go there and learn all about it. I've got, I make YouTube videos with content regularly, Twitter handles, any sort of modern business that you pretty much need that. So there's a contact form there if you want to contact me directly. I always look at that. So that's the best way to get in contact and learn about, what I'm doing. The best way to support the movement is, to really kind of know that just using your insurance and going out. Insurance doesn't equate to healthcare. Just because you have good insurance doesn't mean it's not like you have good healthcare. They're different. And just to know that there's other options available, and that, maybe the way we're doing it, and what I believe, is really not the best way of doing it.
I want to pivot just for 1 second and tie us up with a quote that I read. And I'll read it. "If only I had been given a copy of Dr. Paull's book before I entered medical school, it would have saved me so much heartache and time from taking MCATs through selecting residency and even achieving board certification. Not having this book, I felt like others kept a secret they didn't want you to know. Well, thanks to Dr. Paull, the secret is out." And that was Dr. Polanski on Amazon. I was reading yesterday just one of many glowing reviews on Amazon surrounding your book. So you got into medical school. Now what? A guide to preparing for the next 4 years. I didn't want to let the show get away with us without asking. It's no small feat to write a book, so congratulations. What inspired you to write it?
Well, I don't know. I guess it's just kind of me. I wrote that during medical school, and I kind of finished it during residency. I just didn't think there was a good guidebook out there, and I said, you know what, I'm just going to go for it, and if it fails, and then it fails, and I guess that's essentially what I'm doing now. But yeah, I just figured I'd write this guidebook. I think it's sold, I don't know, maybe around 1,500 copies over the years. I don't do as much marketing with it as I should, or I don't do any anymore. But that was something that I wanted to put out there. I guess, I don't know. I guess that's part of me and my mentality. I guess that's why I don't really fit too well into the system. I can't keep my head down and just, grind away. I can't, and just real quick, with hospital systems, you have your creativity and ability to take risks, and that'll make you successful as an entrepreneur in this business. And when you're training in the hospital system, they crush that. If you think there's a hospital way of doing things, and there's a system process that you think is totally bonkers, and you say it's totally bonkers, they go, yeah, well, that's how we've always done it. And not just that, they beat it out of you. And that's what happened to me early in my residency. I got in trouble a lot as an intern, not for medical stuff, but because I would see things I thought were ridiculous, and I would say it, and they'd be like, oh, you can't say that. And so when the doc gets out of training, it ends up kills your creativity, kills your ability to take risks, kind of, it prevents you from being successful in the kind of a business entrepreneurial way. And that's built into the education part of it. But I think that's important to know, because without creativity and about ability to take risks, succeeding in business will be very difficult. I mean, that's what all the people in the hospital administration are doing. They're doing all those things. And they say, "Oh, you just practice. We'll take care of everything else." But that's dangerous mentality. They're not looking out for your interest or really your patient's interest.
So, can we be looking forward to? So you got a Concierge orthopedic practice. Now what forthcoming on Amazon?
Oh, I don't know. After I wrote that one, I'm like, I don't think I'll write another one again. But we'll see. I don't know who would buy it. It'd be like an audience of 10 people. But I'm not writing it off.
Well, Dr. Paull, I shared your post on Easy Orthopedics on LinkedIn, and I got 8,000 likes in a very short period of time. You're clearly onto something, and Dr. Barber and I both wish you great success and really appreciate you coming on to share your story.
Yeah, well, thanks. I appreciate you giving me the time and the platform, and I think it's important for people to start kind of thinking differently about what we're doing. Because if we keep doing what we're doing, it's not going to end up well.